Okay, now I'd like to open it up to some question and answers for Dr. Hewett, or to Dr. Embry, and I think there's a microphone in the middle there. Who has a question for the doctors? There we go, right up front, Vanna. Is that turned on?
Hi.
Yeah.
Hello, thanks for coming. It's really nice to hear good information.
You're welcome.
I have a question. I read something briefly that was mentioning that some people have cardiac arrhythmia after some of the intervention. And I wondered if somebody is already prone to cardiac arrhythmia, would they have more likelihood of that possibly happening? Or?
I'm not aware of any significant increase in cardiac arrhythmias after the procedure. Certainly during the procedure it is a possibility. That connection between those two blood vessels I told you about, the superior vena cava and the inferior vena cava, is a short little segment that just goes through your heart, okay? And sometimes the catheters and wires can decide to take a right turn and go off into your heart. And if they tickle the right spot, that can cause the heart to have some arrhythmias. It's a simple solution in the vast majority of cases. We just pull the wire back and put it up the right spot. In general, any sort of medical problem that you have, including a cardiac arrhythmia, you should tell it to your doctor first. It certainly is not a contraindication to getting the procedure done. You're welcome.
Yes, I'd like to ask a question about the time frame between angioplasty and actually stent placement. Are we talking about hours? Are we talking about weeks? How long do you actually take to make the decision whether you're going to stent? As you know, are we on the operating table during this period of time?
Yes, those cases that you saw are immediate decisions. And again, I'd really like to drive this home. You know, the angioplasty in most of these cases performed multiple times to try and maintain a patency. And when that patency can't be achieved, all of these factors are put in the cake bin, mixed up, and we decide whether or not to use a stent.
I've had the angioplasty done twice and at least again now. Is it is it safe to have another one done, or
It's a very individual question. It could be yes and it could be no. I'm going to be honest with you folks. There are some veins that no matter how many times we angioplasty or stent them, they're never going to stay open. Okay? And that's why it's important to have a frank discussion with your physician about that. Having said that, we see quite a few patients in our practice who have been treated and have restenosed. And we feel that it's important when we treat patients that we do what's called a valvuloplasty. We believe in our practice that the valve ring at the lower portion of the internal jugular veins can be stretched. It can be significantly stretched, but that it will slowly but surely recoil in most cases. Unless we stretch that ring just enough to tear it a little bit and break up those fibers, it'll restenose. In our practice, for approximately the last year, we've been performing valvuloplasty, and our incidence of recurrence of symptoms after we do that is quite low. So, in terms of answering your question, is it a safe procedure? Angioplasty is a very safe procedure, extremely safe procedure when performed in appropriate hands. Is it safe or indicated for you as an individual? That's really an individual question. And Bruce, like I've told you, and I'll tell anybody, no, there's no yes or no answers. These are not binary decisions. These are individual decisions that should be catered to each patient. One person may be a good candidate for an angioplasty or reintervention, the next may not be. And it's important to try and find a doctor who's going to be able to give you a good answer to that and not just automatically say yes or no. Okay?
I had the operation on the 22nd in California. Mm-hmm. Why do I always have pain on my left side?
22nd of?
March.
Okay. When we do that valvuloplasty and we tear that ring, that can cause some inflammation and some pain. And some patients have had some degree of pain for several months after the procedure. So if you still have some pain there, it's not, I would say, atypical. Typically, non-steroidal anti-inflammatory medicines, Tylenol or an ibuprofen, are typically good enough to handle that. If it's not, please come and talk to me, okay?
Thank you.
You're welcome.
We heard that from one physician in this area, that if a person has the venoplasty done again and again and again, that it's going to destroy the vein and make them totally unable to get a stent placed at a later date. And I would really like to hear your opinion on that comment.
I think that's another one of those non-binary answers. And by binary, I don't think it falls into an easy yes or no answer. I don't think you can, in a broad sense, say that multiple angioplasties are going to lead in any specific direction. I would agree in the sense that I would rather not perform multiple angioplasties on anybody for any reason, okay? In an ideal world, we'd perform it once and it would be fine. I think that in the case of CCSVI, there are some subtleties that may change that view. For instance, we do see patients who we believe needed a valvuloplasty and who have had a valvuloplasty after an initial stretching of that ring, and they've responded very well to it. And in that case, that would be an example of someone who I feel absolutely should have a second angioplasty after they've had the first one. On the other hand, there are patients who have, for instance, veins that are so small that there's not a very good chance of them staying open. And to angioplasty that multiple times is really not indicated, and I would agree. You know, going after that small vein and angioplasty and doing it again and again and again is really not going to lead to anywhere. This brings me back again to, these, broad statements like stents are bad, multiple angioplasties are bad, CCSVI doesn't exist. These sort of things need to be examined from, I think, a more logical and well thought through and certainly a more individual approach. Except for the last one.
There are more and more places
I'm trying to find where you are. Oh, okay, thanks.
So there are more and more places that are opening to treat MS patients with CCSVI, which is good because it creates competition.
Yes.
Why should a patient choose Synergy over some of the more established clinics like Poland, etc.?
That's a good question. I'm actually glad you phrased it the way you did when you say well established. I have patients ask me quite often, how many CCSVI procedures have you performed? And, we've performed a little over 600 and something. Others have performed more. I think that's important, but I think it's perhaps more important to, whether it's Synergy or somebody else, because there's lots of good doctors out there, is to find a doctor that's been performing venous interventions for a very long time and does a lot of them. In our practice, for instance, like I told you, we perform upwards of 10,000 venous angioplasties a year. I've been performing venous angioplasty for approximately 15 years, long before CCSVI came along. And these are the skills that you want your doctor to have. You don't want your doctor to have done 300 CCSVI cases. In my opinion, that's not sufficient. You can do 300 CCSVI cases, I feel, and still not have sufficient skill to be able to deal with the very difficult problems that will often come up. I also think diagnostics are an important part of it. is the clinic you're going to have a good diagnostic scheme for determining if you need the treatment? In our practice, we use a Hakey MRI, which I feel personally is the absolute best way of determining whether or not a person has a problem. It tells us about the flow in the vessels, shows us the anatomy, shows us the amount of iron deposition you have in your brain. And when you need to go for a follow-up, it's apples to apples. That MRI isn't going to change. Now, the downside with the MRI, it's not as accessible, and it's a little more expensive than getting a Doppler study. But whatever it is, whether it's Doppler or MRI, make sure that there's a good plan for going from your diagnostics to your treatment. And I think, you know, what we do and what some clinics do, we have a good plan from the diagnostics to the treatment to the follow-up, and we have the experience. Just make sure that those things are check marks that you find at any place that you go, whether or not it's synergy. Go ahead.
Hello.
Hi.
It's sounding like most MS patients need to have this CCSVI treatment multiple times in order for the relief of some symptoms to hold. Is that the case?
Again, not a simple answer. Yes and no. We do see a lot of patients that are coming to us for a second procedure. On the patients that we've performed valvuloplasty on, we show a low incidence, less than 10% of symptom recurrence. And, you know, granted, that's just for a year. I'd love to be able to give you 5-year data. I can't. We haven't been doing it that long. I believe that some of the techniques that we're using are going to result in longer-term patency, but I can't say that for sure. Okay.
Don't be surprised if we're going to try to get it.
So I understand that at first we were just looking at the jugular vein, but you brought up a very important thing, the valves.
Mm-hmm.
Is that maybe why some patients are having to go back, is because the valves weren't dealt with?
It's our experience in our practice. You know, initially, in some of the very, very first cases, we saw a lot of patients where the concentration was on the middle portion of the vein. And most of us know now that that's just a collapse and or a compression by the sternocleidomastoid muscle. In our practice, many of those mid-jugular compressions are resolved once we treat the valve. Some of them are also resolved when we treat an inflow problem in one of the sinuses. So, you know, it's an evolving technique, and I'm sure it'll continue to evolve.
Guaranteed.
Yeah.
Thank you, by the way.
You're welcome.
Hello.
Hi there.
I have a question with respect to the Hakey protocol.
Yes, ma'am.
What is the advantage of having the Hakey protocol if you don't need to? I know there's the interesting bit where you find out about the iron content on the brain, that sort of thing. But is there anything practical that you can do with that information?
Absolutely. You have a couple minutes? Okay. First of all, the Hakey MRI gives us very good flow data from all of the veins, the important veins in the head, neck, and chest. Using these flow measurements, we can look at areas of narrowing and be directed towards areas that we suspect are abnormal. For instance, in that case where we went up inside the sagittal sinus, that's an example of an MRI pointing us in the right direction. Okay? Little education here. There's MRIs, everybody. Magnetic resonance imaging. A subcategory of MRI is MRV, okay? Magnetic resonance venography. There's also magnetic resonance arteriogram, et cetera, okay? So the Hakey MRI also includes MRV, a very good MRV that shows us all of the veins in the chest and the neck. It's very useful in treatment planning. I'll give you a couple of examples. First of all, there are some orientations of the azygous vein, some anatomic configurations of the azygous vein that are more easily and more successfully approached from the arm as opposed to through the leg. As I'm sure you all know, most of the time you're approached through the leg. Some azygous veins are just easier to get in through the arm. If I know that ahead of time, it makes it easier and safer for everybody. Another example. That stenosis that you saw in my presentation, sometimes we get a high jugular stenosis on a side in the same manner as that. And we've found that it can be very difficult to get through some of these stenoses from the bottom, going at it in this manner. What we found is that sometimes it's easier to just go up the other side, around, and come back down on it. You can understand how knowing that ahead of time would make everybody's life a lot easier. I can sit here and I can mess around and try and get through that forever. Or I can have a pretty good idea based on my map that I have ahead of time to go around. I think most of you would agree it's a lot easier to get across Los Angeles with a map than without one. That's the example I use. Thirdly, it quantifies the iron in your brain. Now, it's a hypothesis at this point what role iron plays. But I think I know, and Dr. Embry also alluded to this, there's a really large amount of data and growing every day that iron plays a significant role in MS. What exactly that role is, there's some theories and some good papers that came out in Italy. So let's just work on the assumption that, iron is a very important player in CCSVI. If we can quantify that and localize it in your brain, like we do with the Hakey MRI, it's not of practical importance now. It's not going to change how we treat you. But the hope and the suspicion is that it may serve as a good surrogate marker in the future to determine the progression of your disease. Changes due to treatment, changes due to medication, many different possibilities. And it's good that we have a baseline in case you ever get it measured again and we want to know something. I'm almost done. I also like to talk about follow-up imaging. If I had my druthers, I'd like to see someone get some sort of follow-up study once a year, at least once a year. For us, the MRI is very useful in that if you can get another MRI, we make a direct apples-to-apples comparison. And I'll just be honest with you, comparing this picture and this flow data to that picture and that flow data, there's absolutely no question. I don't look at it and I go, I wonder if there's something's changed because, I don't wonder if there's something that's different between the two exams. The exams are completely the same. It's not a human doing it, it's a machine doing it. And I can make very good clinical judgments based on that data. Finally, the last thing, CCSVI is like the redheaded stepchild right now, unfortunately. And that's not meant to be insulting, okay, to any redheaded stepchildren out there. It's trying to get respect, right? And the way you get respect in medicine is with research. A lot of the important questions we have about CCSVI can and will be answered with diagnostics. And one of the big diagnostic avenues we're using to do things like look at flow and look at vessels and measure iron is MRI. We use all of these MRIs in our practice to help funnel into research and find these answers so that, say you get treated today, and 5 years from now your symptoms start to recur. I would rather not take you to the surgical suite and do another procedure on you. In fact, I would rather it not be me. I'd rather it be someone in Canada. But what I would rather happen in Canada is that you go and get an MRI or another diagnostic exam where they can look at all this data and say, these are the 3 things that matter, and these are the 3 things that we can treat, and typically when we treat them in this manner, we know it's going to happen. And these are the 5 things that don't make any difference, so we can't do anything about. But we need to acquire that data to be able to make those sort of inferences. And that's the 5th and final thing I like about the Hakey MRI. It gives me lots of fuel to help feed that fire.
Thank you.
You're welcome.
I haven't had an MRI in 11 years. They haven't given me one.
You raise a couple good points. First of all, follow-up, this is not an ideal situation. I would love to be able to see every one of our patients 3 months, 6 months, 12 months in person, right? I think Most of the clinics that are doing this are trying to do the best they can under non-ideal circumstances, and we all realize that we're taking some degree of risk by getting it done in a location far away from home. I would, when you go get treated, definitely ask them what measures they're trying to do to accommodate some sort of follow-up. In our practice, something that I really enjoy when it does occur is in the very rare instance when a treating or practicing neurologist or GP is willing to talk to us, I can at least talk to them and let them know what's going on so that we're all on the same page, right? God forbid. In terms of your restenosis, again, you know, this is something, if you wanted to come and talk to me later on so I could look at your studies and we could approach it from an individual viewpoint, because every one of you are different. It's not that you just have CCSVI, you know, what do your veins look like? You know, where are you at with your disease? What are your symptoms? These are all very important things that will potentially change the decisions whether to re-intervene or not, and many of the other decisions. And I would, you know, if you're thinking about getting a re-intervention or even just getting treated, try and talk to the doctor. I know, you know, ideally you talk to your doctor here. If that's not possible, try and talk to a doctor. In our practice, I probably talk to 60% of folks on the phone, as many as I can. I just think it's important for you to be very well informed and knowledgeable about the risks and benefits of the procedure, and just understand that it's not a cure, right? It's not going to help everybody, but it can help some people.
Hi there.
Hi.
I just want to know, it seems like a side point, is the medicine I'm on, do I just keep taking it because the neurologist will just keep referring me?
We get that question a lot of the time, and I'm going to give you an answer you're not going to like, okay? Are you ready? Yeah, you're not ready, I can tell. I can't and I won't make any recommendations about your MS medications, okay? I don't know you well enough as a patient, first of all. Even after treating you, I won't know you well enough. And I haven't been caring for you for a long period of time such that I can make those decisions. Now, having said that, I know that some patients are faced with the reality of having to make these decisions on their own. And I guess some of, you know, a lot of you, you should probably prepare yourself for the fact that there may not be somebody who's going to tell you whether or not you can and should do that. And it may boil down to a personal decision.
Quick question about the clinical studies that are going on in Buffalo, and Dr. Hakey's involved in a lot of studies. Is any information that you're getting from the patients going into any type of study?
Yeah, we're involved with the registry with Dr. Hubbard. We just started that. It took a long time for it to get going. We're on the process of hiring our own research coordinator to do some of our own studies as well. I'm actively participating in some studies with Dr. Hakey as well. I read way too many MRIs in that regard.
Now, for the Hakey protocol, you need a Tesla 3, I understand, to run this software, that SWI software?
Not exactly. You can perform it on a 1.5, but the data derived from a 3 Tesla machine is better. Let me put it to you this way. If you can get a Hakey protocol on a 1.5, take it. It's better than a regular, you know, it's better than a lot of other things. If you can get it on a 3T, that's better.
I had my intervention back in November, which worked out very well for me. I'm quite pleased by it. Now, there continues to be a struggle between neurologists and interventionalists like yourself in Canada. Is there any progress being made in the United States? Have you experienced the same thing?
You know, it's interesting. It's almost as though there's this invisible wall between Canada and America, not just for junk food, but also for CCSVI. You know, here you come up here, it's on the news, it's everywhere, it's all over the place, it's in the newspaper. In America, I've heard it on NPR one time. Why? I don't know. I mean, you know, I could take a lot of guesses. I suspect that when it comes to the fore, as I'm sure it will be, we'll, you know, MS patients in the US will experience the same problems. Now, what may be a little bit different for patients in the United States is that by the time that happens, there'll be many clinics where patients can get treated outside the hospital. The hospitals are very resistant to do it, much as the, you know, institutionalized hospitals in Canada are resistant to do it. This is more due to legal resistance by hospitals in the United States. But unlike Canada, there's a lot of private surgical facilities where patients can get their procedures performed.
Okay, hello.
Hello.
I was in BC and had the duplex Doppler test done as well as the MRV.
Mm-hmm.
And during the duplex Doppler, this was way back when I had just started doing it there, the doctor who performed it, as he was performing it, he said, breathe in deeply, hold your breath. And the vein bulged, it opened right up. And he said, see, you don't need the surgery, you can fix it yourself. And I said, so do I need to deep breathe like that all the time for the rest of my life?
It's a good question.
So that's one part, I just kind of wanted you to explain that. And then the other part is, after receiving those tests back, nobody would read them. Like, you mentioned talk to your doctor and make sure you have a good doctor and blah, 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 but I'm sorry, I don't mean blah, blah, blah. But yeah.
It's okay. Trust me, at this point I've got a very thick skin.
This is why I didn't want to get up here and talk. But nobody will touch us here, just so you understand.
Yes.
Our neurologist, like, we can't speak about it. And as soon as they find out that we have MS, we're really shut down. Like, it's really bad.
I know these things, and it's a profound mystery to me. I was telling someone just the other night, in Los Angeles, for instance, you can, well, let's start in Mexico City. You can have someone with prostate cancer get on a plane in Mexico City, fly up to Los Angeles, walk out of the airport and walk into an ER in downtown LA, and guess what? You get treated. Now, if you can do that, it's a profound mystery to me how, you know, I'm not trying to be judgmental here, but I would prefer that doctors speak to their patients even about subjects that they don't agree with, they don't condone, even if they hate, you know? It's part of my job to listen to you, even if I don't like you. Okay?
So the next part of my question, so the first is the breathing and making the vein bigger. So I had no one to read it, so I looked at it myself, all the tests from the MRV, and I mean, I could see the blockages. I could see the blockages in my head and obviously in the neck. And I'm not a doctor. But, so in me having that information, am I able to send it to you? Can I pay you to look at it and give me, you know?
You're not going to have to pay me to look at anything, okay? You're going to be one of hundreds of patients that just sends me their material and I look at it, okay? Yeah. This is the important part. You know, a lot of this radiology stuff, it looks like pre-cable television. It's very difficult to understand. Don't beat yourself up over it. You know, find a clinic that performs the procedure and, you know, tell that doctor or that clinic, I'm sending you my information. I want you to look at it and tell me what you think. It's as easy as that. Shouldn't cost you a dime.
Thank you.
You're
and
welcome.
What about breathing? Like
You'd have to get a lot of practice. I don't know how you're going to do it in your sleep, too.
Hello.
Hi there.
I'm scheduled to come down there right after Easter.
Okay, we'll look forward to seeing you.
Very nervous and excited. I have a question
question about the medication. I never touch any conventional medicine or painkillers or anything. I had 3 babies, never touched the Tylenol.
I'm going to clap for that one.
However, I'm scared of dentists, and I want to get some dental issues out of the way before I come get proper blood flow. My question is about all the natural remedies I take, like fish oil and multivitamins for 50 plus, and
You're 30 plus, right? You don't mean 50 plus.
yeah, no, 50 plus.
Okay.
Do I have to stop them 2 days before? Like, what about the fish oil? It helps me greatly with inflammation.
The large majority of your medications are fine. Really, the primary ones we're concerned about are the things that have a significant therapeutic thinning of your blood. Things like Coumadin, warfarin, heparin, things that are going to thin your blood out. Most of the other natural medications, vitamins, supplements that you take are not going to significantly or really impact at all the procedure that we perform. Every patient that comes to us, we'll take a list of your medications. We have it screened thoroughly to make sure that you're not on any medications that are going to cause a problem.
Okay, what about getting an MRI done here on the 23rd and then coming down and on the 27th?
Now, when you say MRI, do you mean MRI like a typical MRI, a typical MS MRI?
Yeah, just a typical, yeah.
You know, that really doesn't affect us one way or the other. It's not going to help us because seeing those lesions in your brain or your spinal cord isn't going to affect how we treat you or whether we treat you, quite frankly. We have had patients in the past come to us without any diagnostic information. We really tried to steer away from that. Okay, we would really like for the venogram to not be the first diagnostic test that we do on you. We prefer that you have some diagnostic tests, whether it's a Doppler or preferably a Hakey MRI before you get the exam. So in regards to that specific MRI, if you have orders from your doctor to get it, I would say get it, but it's not going to change what we do.
Okay, thank you.
You're welcome.
Hello again.
Hello.
I didn't understand from your talk why, if 95% of the time you do angioplasty, why your focus of the talk was on stents.
Just to stir things up. No, honestly, I mean, I think probably most of you have seen lots of talks about lots of things about CCSVI, and I could come to you and sit in front of you and give you a talk about things you've heard. I could talk about my practice, I could talk about a lot of things, but what I want to do is take a subject that there's a lot of, what I believe, information coming from a lot of different directions, and perhaps give you a framework that at least now you can go back and you can get on the internet and you can ask your doctors and try and distill that down into something that makes sense for you, something that has a lot of voodoo associated with it. That's why I talk about stents. Please.
Thanks very much for giving us, incidentally, all this hope, because last year at this time when we were meeting, there wasn't nearly so much hope as there is now.
Well, you're gonna, it's, you know, I got to tell you something, if you don't mind me interrupting. Yeah. If all of you could have been at the meeting in Italy, you would have all seen that there's this wave of evidence, wave of enthusiasm, wave of support for the concept of neurovascular causes for neurodegenerative disorders. And I think you're going to see a lot more of that in the future.
Okay. On the other side, you've used the word risk quite often. Mm-hmm. What is the downside experience that you, either your group or what you know about going on in the United States? Are there people that have negative outcomes from the procedure?
Well, let's talk about risk first. The procedure itself is very safe. And, you know, it's another source of misinformation. I've read on the internet several times how this is a very risky procedure. I don't know why well, I can imagine why people would say that, but in reality, it's not. When it's venous angioplasty, okay? Let's just get that straight. It's not something magical. It's not something arcane. It's not a big mystery. It's venous angioplasty. And there are people out there who've been performing venous angioplasty tens of thousands of times for decades. As a result, it's a safe procedure when performed by the right people. Are there negative outcomes? Yes. In our practice, we have a 1% complication rate by the best measures we can find. Most of these are minor complications, things like bruises and stuff. Have we had people thrombose? Yes. Have we had people restenose? Yes. But I think in our practice, like perhaps some other practices out there, we are trying to practice our craft at the highest level that it can be practiced to cut down on those things. And in so doing, our rates of these major complications are quite low. The things that we don't do, you'll never see us put in a stent that's too small, for instance, which is a lot of, you see a lot of this in the news in Canada. This person has a thrombus and, they went to Costa Rica and all these problems. And I think that people are, in a sense, being misled by that information to thinking that the procedure is very risky. I hope that answers your question.
I have a question. What does restenose mean? Does it mean after you've had the stent, or?
It's a very good question because people use it to mean different things. In my mind, restenosis is a process that occurs gradually. If we angioplasty something, or if we stretch something, or if we place a stent, in colloquial terms, it's the slow accumulation of scar that gradually narrows a vessel. In my mind, it's somewhat of a misnomer to call an immediate short-term collapse of the vein with thrombus accumulation a restenosis.
Thank you.
You're welcome.
One more question, and this is for Mark. He's sitting here.
Okay, Mark.
He wants to know, after being in a wheelchair 20 to 25 years, he wants to know how much hope there is if he were to have this procedure.
It's a good question. I'm not going to lie. Some of the longer-term disabilities are much more difficult to treat. In our practice, and if I'm repeating myself to some of you, please bear with me. We think CCSVI is a distinct diagnosis. Okay, there's CCSVI, and there's MS. Okay, we're also treating people, and you'll be the first people to hear about this. We've treated people with Lyme's disease successfully. Parkinson's disease, same problem, okay? Which in my mind lends even more credence to the fact that this is a reality. CCSVI symptoms, fatigue, headaches that wake you up from sleep, difficulty sleeping, cognitive dysfunction, autonomic difficulties, bowel and bladder dysfunction, for instance, thermoregulatory problems, cold hands, cold feet. These are very typical CCSVI symptoms, okay? These symptoms have almost a uniformly good response to the treatment in our practice. Respond very, very well. The denser symptoms of multiple sclerosis, significant motor abnormalities, significant sensory neural abnormalities, have a more variable response. That's the best way I can answer that. I would love to be able to say, you've had MS for 20 years, you have this many lesions in these locations, and this is what your veins look like, this is your suspected outcome. You'll have to wait a number of years to be able to try and get at that answer, though. And I apologize for that.
Dr. Hewett, yeah. Thank you for taking your time to cover today. I appreciate that.
Oh, you're welcome. Actually, you know what? I really enjoyed talking to you folks.
I brought my wife, Carol, to your facility back in August the 9th, actually.
Mm-hmm.
She was treated by your colleague, Mike Florada. And we've had some subsequent discussions with them, and we're pretty certain she's restenose. And what I was curious to know is, and I'll just also perhaps add, she had over 90% occlusion of her azygos,
mm-hmm.
and I think it was 60% in the right jugular and about 50 in the left. And I was just curious to know, are there any new techniques or equipment that you're using since we were there in early August? Because at that time, Dr. Rudd was talking about larger balloons, cutting balloons. I know you mentioned the valve treatment, and also of the restenosis that you're aware of there, is there a certain percentage that is associated directly with the azygos versus the jugular?
To answer your last question first, whether there's the incidence of restenosis in the azygos vein, I can't answer that specifically. We haven't looked at that specifically. We're in the process of trying to get those answers. The azygos vein is a difficult vein to deal with, and exactly determining what is restenosis will be one of those challenges. In terms of has anything changed since August, I would say not appreciably. The goal in our practice then, as it is now, is to perform that valvuloplasty. It's not, again, a simple this or that answer. We use large balloons, we use high pressure balloons. If we have to, we'll stack 2 balloons next to each other to stretch it in an asymmetrical fashion. If we have to, we'll put a wire next to a balloon to score the valve to help get that valvuloplasty. If we have to, we'll stack balloons that have blades to try and score that valve as well. I'll just stop for a second and I'll tell you, Mike Arata, he's my senior by about 4 years. And this man, he's a genius, all right? He's probably one of the 5 most accomplished interventionalists in the world, in my opinion. And if it was, I would not hesitate to send anybody to him. So I'm going to work on the assumption that whatever he did for your family, that it was at the highest level of treatment possible. Having said that, I would love to look at your case, and if you're willing to, send in, I'm sure you've sent your information, but talk about it some more and see if there's anything else we can do or what can be done.
It's obvious that you and your team are very strong proponents to the treatment, very knowledgeable up here in Canada. Not only do we have to do all the clinical studies, but then we have to train the doctors and bring them up to speed. So
Yeah.
years away from being able to offer this like you do down south. To make a long story short, Alberta Health Services dropped the ball some time ago. Do you remember the clinic that was doing the private clinic that was doing the hip and knee replacement surgeries that went bankrupt some time ago? Well, they bailed on their lease. There is a fully functional, privately owned hospital that sits empty, that's never been used here. 72 beds, 6 operating suites. There's got to be a use for that.
You would think.
So can we entice you or somebody you know?
It's a very good question. Listen, I'll tell you straight to your face, I would be happy to come up here and do the procedures. It would just make everybody's life a lot easier. We could do them in California, we can do them here under the appropriate circumstances. The problem is, first of all, getting a Canadian license, a medical license. I'll let you in on a little story. I attempted to get a British Columbia license to read some MRIs as part of this research that we do. I was shut down like you wouldn't believe. There was no convincing these folks that they were going to give me a license. I'm a Canadian citizen. So as much as I might like to do that, and I'd be willing to do that, the chances of that happening are probably slightly less than a you-know-what and you-know-where.
But if you're a foreign doctor, you can get a taxi license, though.
Well, I just saw on the news that I can get retrained as well. I think that was the Liberal Party. An MRI, the Hakey MRI is $2,500. You're welcome.
Just a question for you. Is it possible to come to your clinic and get treated and opt only for an angioplasty, and for whatever the reason may be, indicate to you that I didn't want to stay?
Absolutely. I'm glad you asked that question. I forgot to mention this. We have patients come all the time who say, Dr. Hewett, I've heard what you said and I'm listening to what you say, and maybe even there's a good reason, but I don't care what you say. I don't want to stent. And we say, absolutely. We do the vast majority of what we do with angioplasty. We do it thousands of times per year. We've been doing it for a very long time. we can do most of what we need to do with angioplasty. And as long as you're comfortable knowing that, you know, there's a very, very small chance that we may not be able to keep your azygos vein open, for instance, absolutely we can do that. You know, again, this sort of comes back to patient-centered medicine. What's that, right?
I have a question about blood clots forming.
Please.
When they do form, how easy is it for the body to get rid of them, or is it hard to get rid of them?
You know, again, this is not a simple question to answer. The analogy I like to give people about blood clots and blood is it's like a stream. If you have a nice healthy stream that has a good flow, everything's good. You got fish, you know, and the plant life, everything's fine. If a big tree drops across that stream and the flow starts to stop, that's when you start to get the pond scum and things start to go awry. It's the same in your bloodstream. If you have good flow, it's much less likely for those clots to form. If those clots form, the simple and broad answer to your question is, if clots form and we can get to them soon, typically they're not that difficult to deal with. If we wait a prolonged period of time, they become more difficult to deal with. We want to have the closer we are between good flow and bad flow to treating the easier things are. Once that flow is cut off, and that flow's been cut off for a long time, it becomes difficult. And this is another one of these individual situations. If you come to me and you say, I'm thrombosed, can you fix me? It's not an easy answer. Depends where the thrombosis is. Depends on what the flow into it's like, what the flow out of it's like, what it was like beforehand. Many, many, many factors that there's no simple, single-sided answer to.
What if, say, Mike's going to come down to California and get this? He's already had blood clots one time, and everything's cleared up. He's not on thinners anymore. Is he still a candidate?
Blood clots where in Michael?
Those in his leg.
Okay, yeah, that's a different story. He probably had blood clots in his leg due to immobility. Yeah. It's not really a significant factor, I would say, in determining what we do. It shouldn't have a significant influence on whether or not we're going to intervene up here. Again, it's somewhat individual. If he had significant blood clots in his leg, that may influence how we go in and do the treatment. But keep in mind, during the procedure, Michael would be anticoagulated, so he's not going to form a blood clot then. And depending on his, all of our patients also get anticoagulated after the procedure for some variable period of time to help decrease whatever small risk of clots there would be. Long answer to a short question. The short answer is no, not really.
My question is about grafting. Do you do that? And my other question is, what percentage of stenosis before you're not a viable candidate for this treatment?
So by grafting, do you mean like vein bypass grafting?
Yes, that's exactly right.
Yeah, it's a good question. So basically we're talking about someone, for instance, who has such bad disease or has been intervened on multiple times that this jugular vein, for instance, is not going to open up, and maybe we consider tying a vein up here and sewing it in down there. First of all, I'll tell you that it hasn't been studied, so I don't have good answers to that. We can look perhaps to some other areas of the body that's been tried. For instance, treating May-Thurner syndrome, it's been tried. Treating other venous obstructions in the leg, that's been tried. And the outcomes have not been good. Where those sutures, those stitches are put in, those tend to close off. The flows through these grafts tend to be so slow that they don't stay open well. As a general answer, it's probably not a great option. I'm happily proven wrong, though. And your second question was?
The percentage of the stenosis before you're
Again, it's a good question. It's an individual question. It really depends. We have patients who come in with quite tight valvular obstructions that respond well. And I guess at the far end, I would say, if you have a jugular vein that's just a small jugular vein, and we look up and we see there's very poor inflow, there is definitely a decreased chance of that staying open. That's sort of at one extreme. And then it's really variable. It would really be much more helpful to be able to look at a diagnostic study of you to make have an individual discussion with you about that, or any patient.
Hi.
Hi.
Both of my parents here have MS, and I'm just wondering, for me, if I should be having my veins checked, or if I should just wait for multiple symptoms to come up, or what do you think?
You know, it's a good question. It's a question really that you're going to have to answer for yourself. I can tell you, in our practice, we've had situations like the one you're presenting with your parents, where the parents or the child has decided to get a diagnostic study, not the intervention, not a venogram. I don't think we've had anybody who's decided to have a venogram based on this situation, but we have had people get an MRI wanting to look at the veins and see if there's anything there, and look at the iron deposition.
And my second question is, do you offer financing at your location?
We do not. We're looking at a type of, they use it for plastic surgery. It's the same idea that would offer would result in the same thing. I'll keep you posted.
Can I ask a quick question again about clotting? We went to see Dr. Arata in September, and we had the angioplasty, and we didn't have, we weren't prescribed blood thinners. I looked in your paper today, and it says that you have blood thinners for 2 weeks now. Is that new, or? It is new.
When we first started, you know, and again, it's an evolution. When we first started doing this, we were sort of standing in a position where if the flow is good, there's really no reason for blood thinners. And truly, if we get a super outcome from the procedure, blood thinners may not be necessary. We've evolved, in large part, we don't want to take even that small chance, so we want to give a little bit of extra insurance, okay? Not enough that it's a danger to the patient, but enough that there's just, you know, it lowers, you know, whatever small percentage risk to almost zero. I guess you could call it continuous quality improvement.
But it wasn't really the result of numerous clots afterwards.
No,
right?
not at all. Not at all. Yes, I know you've been waiting for a while.
My left anterior jugular was blocked and I was stented. It's about 6 months. What recourse do I have to take?
It'll depend. I would like to see what size stent, what it looks like, what your flow is like, a couple things. Putting that aside, you know, if you have good flows, it may be better to do nothing. If you have poor flows and you have recurrent symptomatology, some of your unwanted symptoms have returned. We have had patients, much as yourself, who've had a stent placed there that we've intervened and we've had to open that stent up to have a much bigger flow channel.
What happens to the stent?
Well, that stent, after about 6 weeks, is covered with skin, so to speak. It's you could call it blood vessel skin, I suppose. And that stent, if it's too small, what we're going to do, we're going to take that small stent, we're going to use a high-pressure balloon, typically, and we're going to fracture it, just open it up. Pieces don't fall off, it's just sort of pulled apart. But there are tines of the stent that tend to stick into the lumen. For that reason, and to be safe, we have to take another stent and plasty that up to tack everything down against the wall.
So that will happen? That procedure in time will happen to me?
I can't say that for sure. It really depends. It depends what size stent you had put in and where it was put in. Exactly. And what your flow is like as a result.
I seem to have good flow. I had a doctor done recently, and that's all I really know of my right side. My leg just swells up very easily.
And you know, there could be a lot of reasons for that leg to swell up. You know, I'd like to look at what your documentation, your diagnostics look at there, and I'd like to talk to you some more about the hows and whys and whats of your right leg, because there's a lot of reasons that right leg of yours could swell up.
Thank you.
You're welcome.
Hi.
Oh, okay, gotcha.
Yeah, it's on now.
Okay, I just wanted to thank you first of all for coming to talk to us, because I'm on Facebook a lot, and it's nice to be able to talk to somebody in person.
Yeah, it is, isn't it?
Thank you very much for that.
You're welcome.
Another question that I wanted to ask, I'm looking at your procedures, and just a point of clarification, because I don't know what I'm talking about sometimes. What's the difference between a venogram and a Hakey MRI, and is it included in your cost?
It's a good question. So the venogram is actually part of the procedure. When we go inside your veins and we inject the dye, and we take the pictures with the X-ray machine, that's a venogram. The Hakey MRI is separate. When we do the Hakey MRI, we do a magnetic resonance venogram. Two distinct things, and it's not included in the procedure. The reason we don't include it in the procedure, because we do have patients, for instance, who come and have had their Hakey MRI from False Creek or elsewhere.
So if we were to come, we've had no diagnostics done, so we should probably have the MRI before we come?
That would be our preference in our practice, yes.
Okay, thank you.
How about a jugular veins ultrasound? Scheduled for that? Is that
We do have patients who come to us with an ultrasound as a diagnostic tool, and we have accepted that in the past. Okay, I'm going to tell you why we've changed our tune. We have not an insignificant number of patients who present to our practice with a diagnostic ultrasound that tells them that they don't have CCSVI, or there's nothing significant. I'm sure you're all aware of the Zamboni criteria. 2 being that you're a so-called candidate for the procedure. We have a lot of patients. I don't feel like I'm exaggerating when I say that. We have a lot of patients who come to us with 0 and 1 out of 5, who would typically not be candidates. We perform the Hakey MRI on them, and we find many of the abnormalities that I've seen and that you've heard about that can and are treatable. Okay, and this is why we prefer to have a Hakey MRI.
Sure, if you will. Can you give those of us in the room some advice on other things we might be able to do? If we get treated and we re-stenose, or we're waiting to be treated, or we can't afford it, what other things might we do to improve our vascular health such that, you know, we might reduce symptoms in the future or improve the symptoms that we have now?
You know, these are good questions. I've never been asked that before, so I'm going to try and wing it. Okay. I would say, in general, some of the things that you've talked about with regards to this doctor, I really like the fact that that individual is looking at those things. When we do MRIs, and we happen to get a patient whose head is turned, we see compression and we see poor flow. And, you know, if you think about MS as a long-term progressive disease, in my mind, I think that even small things done on a regular and intermittent basis over many, many years could probably make a difference. So if you could not have your head turned off to the side compressing your jugular, you know, I can't see how that would be a bad thing. You mentioned perhaps sitting a little more upright. May not be a bad idea. You know, the premise behind CCSVI is you have blockages. Increases the pressure above the blockage. That causes the blood-brain barrier to break down. You have leakage of red blood cells into the brain. Red blood cells contain hemoglobin. Hemoglobin contains iron, right? Inflammatory reaction, MS plaques, you all know this. If you can do something to perhaps encourage that blood to leave your brain, maybe that would help. Other easier answers I could give you, I say if you're smoking, stop. Please, everybody, stop smoking. Stop smoking. Okay? You know, a lot of you should all know that smoking hurts blood vessels. So stop smoking. There also is some research suggesting that, you know, some of the problems associated with CCSVI are due to oxygenation. So if you're doing things that cut down on your oxygenation and your general vascular and just health in general, you're not doing anything to help your problem, right? So if you're overweight, try and lose a little bit of weight. If you can, try and get a little bit more exercise, eat better, just be healthy. I'm not going to go any further out on a limb than that, okay? There's people out there who are probably better able to answer that question than me.
Hi.
Sorry. Please, go ahead.
I'm scheduled for, with Dr. Harris at the beginning of May.
Yes.
And I was just looking at this thing with Dr. Bill Code's 10 recommendations. Now, how much significance do you put on that?
I think Bill Code has a lot of good suggestions. I think he's a very intelligent and well-meaning individual, and I give a lot of credit to what he says. The reason you have that in your hand, in our efforts to present patients with good follow-up information, we've put together, for lack of a better term, what we call our CCSVI Bible. And we've gone out to experts in the fields of nutrition, physical therapy, and imaging, and tried to collect this and offer this to our patients, not as dogma, but as advice. If you believe that changing the way you eat and the supplements you take may help you, we offer that as advice from someone who's considered an expert in the field. I hope that answers your question.
Hi, I have a quick question. What criteria would you need to see on a patient to operate if we're not able to have an MRI?
Well, first I would ask why, if there's the way you say it, it almost implies that there's a medical reason you aren't able to get in. Okay. Now, having said that, I'll have you know that we can do MRIs on people with pacemakers.
We actually do that here in Calgary, and they refuse to do it on me. The risks are too high.
Okay. It depends on the pacemaker. Let's just assume that you can't have one done. That's a special case, okay? If you can't have an MRI for medical reasons, if you can get a Doppler, that'd be great. If you can't, we can just take you and do a venogram, okay? It's not a perfect world. We're going to do what we have to.
I'm one of your 10% there that when I had my procedure done at Pacific Interventionalist.
Where are you? I'm trying to find you. Okay, yeah.
Less than 4 weeks ago,
okay.
And I had miraculous results actually for the first 2 weeks. I was 5 for 5 for your criteria for CCSVI. I was only diagnosed with MS less than 6 months ago, and I had 100% stenosis on my right side, 60 plus on my left side.
Okay.
And I fell downhill pretty quick.
Okay.
Going back on Tuesday actually to get redone.
Okay.
Without any testing, Dr. Rada's going right back in there.
Okay.
But what would you consider that, a restenosis? Because I was absolutely phenomenal for 2 weeks, and then all of a sudden I started to get some symptoms back, some symptoms versus mobility, and now it's my cog fog is back, and I'm worse than I ever was.
It's difficult to say without talking to you more, Mark, and sort of getting into your symptoms. Could it be restenosis? Yes, possibly. Could things have closed back up? Could there be some component of thrombus somewhere in there, not endangering you in any significant manner, but something impeding your flow in that manner? Yeah, I think colloquially, in very general terms, we could talk about restenosis.
Yeah, because like say my pressure headaches have come back, where I lost 100%. And like say, I'm going to get redone here, and like say, it's pretty amazing what happened to me after my procedure and what happened to me within 2 weeks. It's something else.
Yeah, what I would really like to see from you, Mark, is your diagnostic studies beforehand, just to be able to talk to you about, get some realistic idea where we're at and where we can expect to go, even with a repeat intervention. And you're going back to see Mike Arata? Yeah. I have your phone number, and I wanted to talk with him about your case, and I'm going to be talking to you in the next day or two, okay?
I have a doctor tomorrow morning here in Calgary, and I'll be getting back to him after that.
Okay, yeah. Let's plan on talking after you get your Doppler then.
Yeah, I'm hoping they'll be able to give me our results to bring down to Pacific Interventionalist and Dr. Arata here next Thursday.
Okay. Perfect. Next. Melissa, right? Yes. It's like a steel trap.
Hard to forget. My question is, I guess, if you suspect you're restenosing, what is your recommendation as far as, I mean, I did great after my procedure. I'm 8 months in, and I'm still better than I was prior to. However, I mean, is it imperative to get it done as soon as you notice your restenosis? You know, do I go by the line in my head that I've drawn of where I'll let myself get again, or is it, you know, am I going to benefit more?
It's a difficult question. After a procedure, I would like to know that you as a patient have reached a point where you're stable in terms of, you know, things aren't fluctuating anymore. It's not due to perhaps the stress of a plane flight or something else, that you know where you're at, right? And then I would like to be able to look at all of your imaging studies and talk with you at that point. Go ahead. I know, and we looked. Oh, that's right, I hadn't looked at them yet. Actually, I think I lied to you about that. We'll talk. Yeah, that was my fault. I was looking at it wrong. See, this is good. This is a doctor willing to admit that he's wrong. So we're going to look at those, and we're going to talk about your clinical situation. Again, folks, this isn't something where I can say to you, if you have recurrence of your symptoms within 2 months, you must get re-intervened. It's just, you know, the veins inside your head and neck are different, every single one of you. Your clinical symptoms are different, every single one of you. And you put all those factors together, there's no easy answer. What may be, yes, we can take you in and we can probably make you better. For one person, maybe, you know, there's really no point in doing this because, quite honestly, there's not a whole lot more we can do for you. You won't be one of those, Melissa.
Can you share any highlights from the conference in Italy?
That's a long talk. Highlights in very general terms. Much more data about how the procedure is safe. A lot of the things that, you know, we as people who are familiar with this may go, so what? But these are important things. A lot more data about how it's safe. A lot more data about the high 90+% percentage of people who have MS have CCSVI, as Dr. Emery alluded to. Very interesting presentations on the association of iron with MS and its role in the process. I find that very interesting. Some presentations by Dr. Zamboni about a new device he has. It's a cervical strain gauge plethysmography. Say that fast. It's basically a collar that would, in a sense, go around your neck and be used as a very, perhaps, effective screening tool to determine whether you have CCSVI or not, much as a Doppler might. Some very interesting presentations on something I alluded to previously on the more generalized role of vascular disease in the development of neurodegenerative disorders. And I think that's really where the International Society of Neurovascular Disease, which is the society that I would encourage all of you to look into and become familiar with, because that's going to be one of the societies that really pushes this research forward. That's really going to be the role of the International Society of Neurovascular Disease, looking at the role of vascular disease and what role it plays in neurodegenerative disorders. I can't quite remember anything else right now. You're welcome. Please, go quick. Okay.
We have a friend, my mom has a, she's been Las Cabos for the liberation. She's restenosis. If she comes down to the procedure, it goes anywhere other than Canada, obviously. If there was any thrombosis or blood clots, how fast? Like, we can't get that looked at here. So do we phone you right away and fly her down?
Well,
she's in a wheelchair.
in a general sense, I would say any question that you have, call us right away. You know, anything that concerns you, you should call us. You know, the question of how to deal with thrombosis is a very difficult question, okay? I would like to tell you that a lot of the thrombus that would form in a very slow forming vein isn't necessarily dangerous. the thrombus is forming is because the blood flow is cut off or very significantly diminished. It's unfortunate in the sense that your vein isn't open and not flowing anymore, and the earlier that it can be treated, the better. I guess I would just end by saying that, you know, there's no good answer to that. What should happen is that if you do have a thrombus, you could go and get it evaluated, probably by Doppler in the short term, and proceed from there depending on what the Doppler says.
Because normally nobody's going to look at the MRVs, if you have MS.
Yeah, I know.
Stroke, it's a different story.
Well, yeah, and you know, it's a crime in a way that if you have a significant medical problem that you're not being treated. I wish I had better answers to give you in that regard.
The second one is she's on a catheter. So if the procedure, it worked for a bit, but it didn't. So if it were to work where, like Michelle, you know, she goes to a pain, the catheter, how does that?
What do you mean by a catheter in her bladder?
Yes. Like she has to relearn everything? Like, is that an automatic?
I don't quite understand.
She's wondering if she'll get relief from the catheter.
Okay, excuse me. So, again, not a simple answer. One of the things we see very, very frequently with CCSVI is bowel and bladder dysfunction. And it's one of the things that responds very well. Okay? The fact that she has a catheter implies to me that she may have had this dysfunction of her bladder for quite a long period of time, and it may be quite significant, which would imply to me that the response to the treatment is more variable. Okay, it's definitely not a sure thing, and the odds might be lower than may not be good. They're probably pretty low. Okay. Having said that, we have had patients who have had significant improvements in their bladder function.
And third, we have a friend who has MS as well in both toes, and his dentist actually took a jaw impression, and she told me that he was going to Italy for the convention with this imprint, thinking that the jaw had something to do with MS.
Well, there is some research being done, and you know, you can read about it. This falls into this large category of, you know, there's possibly a lot of different scenarios that influence blood flow out of your vein. Perhaps jaw position, perhaps muscle tone in your neck, perhaps muscle tone influenced by jaw position. These are things that I'm sure will be researched more and we'll have better answers in the future. I would just recommend to you that you just keep reading the internet. That's about as much as I know about it.
I have a friend who has...
I know.
Oh, sorry.
We'll get back to you.
I know the treatment's fairly new, but how long is the longest case study? And then also, are there plans for longer case studies with this treatment and MS patients?
Yeah, absolutely. You know, there's been retrospective studies containing hundreds of patients that show that it's safe and have favorable outcomes. You know, what everybody wants, including the medical community, are randomized controlled trials, right? And those are in the process, and they're moving forward. And there'll be large randomized control trials also, I've been told, up here in Canada pretty soon, I've been told. Yeah, and you know, hopefully that'll quiet some of the detractors when the positive outcomes from those trials come through.
Thank you.
You're welcome. There's one up here.
I just had a quick...
Okay, well he's walking, yeah, why don't you squeeze it in? Go ahead.
I just had a quick question. I have a friend who has early onset Parkinson's. She wasn't able to make it tonight. Have you treated anyone with Parkinson's at this procedure?
We have.
And what kind of outcome?
They had a good outcome. Yeah, I'm not going to be one to stand up here and say people with Parkinson's are going to have very good outcomes from this in general, but we have had a Parkinson's disease patient that had a good outcome. We've also had a Lyme's disease patient that had the MRI, showed very typical signs of CCSVI, displayed classic CCSVI symptoms, and also had a very good outcome.
There's a fellow recently had a treatment
Organic treatment in Germany, they also did the stem cell.
Stem cell transplant, yeah, treatment. Mm-hmm. What's your question specific?
Have you ever considered stem cell treatment in addition?
I am no expert on stem cell treatment, and I would probably be the last person to ask about that, quite honestly. I would say this to you: if you're considering stem cell treatment, I would definitely do your research, okay? Try and find out if there's any studies or any data that support it being done. And I would also ask some specifics about how it's done at any particular location, the standards they use relative to it being done at other locations, perhaps using a large research institution in the US or Canada as something to compare to.
Thank you.
You're welcome. Is that it? Okay. Oh, you've been over your maximum. Only 2 questions allowed. Only if you consider women a race. No. No, you know, but to tell you the truth, we haven't even looked at that. It seems, you know, we see obviously a lot more Caucasians than anybody else, but, you know, we haven't studied that at all. We know that we definitely see more women than men, but that's about as far as it goes.
Would you say that some of those studies could be genetics, or maybe geographical location where you have a larger population?
Genetics, yeah, there's going to be definitely studies on genetics. You know, some of the information in Italy looked at the different phenotypes of multiple sclerosis and how those different phenotypes may have different mechanisms of handling iron in the brain. And when you superimpose those perhaps suboptimal mechanisms of handling or clearing iron in the presence of increased presence of iron in general due to these CCSVI pressures, how that may negatively influence a person's clinical status in MS. So definitely, you know, the genetic component of it plays a role. Geographical, you know, we all know that Canadians as a percentage of the population seem to have a high rate of multiple sclerosis. That's about as far as it goes. Interestingly, though, there was a presentation in Italy on the seasonal effects of multiple sclerosis and how symptoms appear to be more severe in the spring and summer. And, you know, maybe that's obvious to some of you, but I found it kind of interesting that someone did a scientific study on that and proved that to be the case. And maybe that has something to do with geography. You know, maybe if you live in a colder climate, that there may be a relation there. I don't know.
On your trip to Italy, was there any discussion regarding medication for the regeneration of thyroid?
No, not that I recall.
And what would you say, what advice would you give or comment would you have for an individual who may think that they have MS? We have a friend who's actually had treated twice, but has no, there are no lesions whatsoever on his brain. Now, is it consistent to say that people who have MS have lesions, or is that not true?
Well, you know, there's different ways of diagnosing. Typically, people who have been diagnosed with MS do have lesions on their brain. Having said that, I think there are some of us that suspect that neurodegenerative diseases, if you pick the multiple sclerosis and the Parkinson's disease and some of the other ones, that there may be a very broad spectrum of neurodegenerative diseases, and that people may sometimes fall somewhere in between or may have aspects of both. And in that broad spectrum, there may be people who have, you know, some neurodegenerative disorder that doesn't have an appearance on an MRI, that may be showing CCSVI symptoms. We've treated people like that.
Just a note on if it's genetic, I don't believe it's genetic. I'm one of 4 in my family that has it, has MS, and that was tongue-in-cheek, that has MS and also has CCSVI. We've all been treated within the last 6 months with with very positive results. However, we have all regressed or had some symptoms come back. A couple of us are booked in with you actually down there in May to hopefully take care of that. I just thought I'd leave a point here of the 4 out of 6 in our family that have it.
We do see a lot of that, and that's actually the cause for, as we talked about earlier, some family members are getting other family members who haven't been diagnosed. They get a diagnostic study, this Hakey MRI, to try and determine, before someone puts a catheter inside of them, if there's something wrong. Go ahead.
Dr. Hewett,
Yeah.
Heard a lot about iron as a result of blockages, etc. Do you have any thoughts on the chelation treatment? After the CCSVI, I've had the liberation treatment in December, and I'm getting my blood monitored for iron content now. I basically have cut out red meat almost 100%. But I've also been looking into the treatment using chelation. In fact, this sort of came to mind. My wife met a lady who had MS and went through the chelation process, and her symptoms are virtually gone.
It's Dave? What's your name? Rick. Excuse me, Rick. Rick, I'll be honest with you. I am the wrong person to ask about that. Okay? There are people who are much better to ask about that. I know Dr. Code and Terry Jacklin. I'm sure you could send them an email and they'd be happy to answer you about that. I really don't have any significant knowledge about chelation therapy. I would like to believe. I think it would be wonderful if we could supplement our techniques that help slow down or stop iron deposition with something that can actually help reduce the iron deposition. That would be great. Where's here? Oh, okay. Great.
We're hearing about
Thanks.
a lot of restenosis here tonight, the longer this goes on. And I was just wondering if you actually have an idea of percentages at Pacific Interventionalist with respect to people that restenosis.
We look at recurrence of symptoms, and since we've been doing the valvuloplasty, our number is somewhere below 10% for recurrence of symptoms. You know, the nature of the geography, we haven't been able to compare MRI to MRI. And we're going to actually start to do a study, hopefully in the near future, where we have patients who get an MRI in the immediate short term after the procedure to help look at that better. But for now, we have to base it off of symptoms.
Were you before keeping statistics as well? So do you see it?
We weren't keeping. I guess the simple answer to that is no. But I know for a fact that our restenosis rates were higher before we started doing valvuloplasty.
Okay, that's great.
There's no doubt in my mind about that.
Two quick questions. One individual, one general. My wife was treated by Dr. Rana last Thursday. The blood thinning medication she's on for 2 weeks. Feeling very tired and very weak.
Okay. I haven't heard of the blood thinning medication doing that.
Well, I just made that assumption because those were listed as side effects.
Okay, and that's possible. To be honest with you, I didn't know that was a side effect. Were you tired? Did you improve afterwards?
They cut it in half.
Okay.
And when I still had that, I put it out together.
Okay. How long has she been on it?
She was treated last Thursday.
So what's today? I don't even know what day it is.
Today's Wednesday, so it's only been 6 days.
So why don't you cut the dose in half?
So instead of twice a day, one?
Yeah, take it once a day and see if that improves. Okay.
And then if not, maybe just contact
Yeah, in all these cases, the best thing you can do is just call us. Because in an ideal world, to be frank with you...
I had spoken to Sue, your nurse, on Monday.
Okay.
Before we left for home. And so I guess this is saving me a phone call.
No, that's good. I'm glad I could help you. The second question.
Yeah, by any chance, were there other Canadian doctors at this convention that practice in Canada?
I don't know a lot of, well, when you say Canadian doctor, Dr. Code was there. Dr. Code doesn't perform the procedure. I've heard some names. I couldn't tell you if any of them were there. Well, Dr. Sandy McDonald was there, I've been told. Is he an interventionalist? Yeah, he's an interventionist. So he probably, I'm sure he could do the procedure.